Good afternoon, everyone. My name is Nebiyou. I'm a medical director and assistant professor of general surgery at Jimma University Medical Center, Ethiopia. Here I'm going to present on title Patterns and Management Outcomes of Intracranial Extra-Axial Hematomas in lower source setup, which is a 6 months prospective observational study at our University Teaching Hospital. So, as introduction, intracranial hematoma is a collection of blood in various intracranial spaces. So, ICH accounts for up to half of all severe traumatic brain injuries and up to tens of the moderate cases, as well 0.2% of mild cases of traumatic brain injury. And head injury is an degenerative insult, and it is usually responsible for up to 50% of fatalities among trauma patients. And in turn, head injury affects more than 10 million population worldwide, and it accounts for 15% of the burden of disease and disabilities among trauma patients. And in low and middle income countries, the incidence of TBI is estimated at 3.2 million per year. And it is well known that we're in epidemiologic transition, so low-income countries suffer triple burden of disease. The first is infectious disease, which are being decreased by some proportion, but there is a still rising incidence of non-communicable disease. And also trauma is the third commonest cause of healthcare burden. And with a 3.5-fold increase in the sub-Saharan Africa, it is estimated that it will be reaching 40 million injuries per year by 2050. Acute peripheral hematomas and subdural hematomas are types of intracranial extra-axial hematomas, and they are usually life-threatening complications of traumatic brain injury. Likewise, acute subdural hematoma is the severest form of all types of intracranial hematomas, and the mortality can reach more than 60% based on the severity of that. So the methods we have employed in this study is the study site is Jimma University Medical Center, which provides services to a catchment area of 50 million people with reaching 2,000 staffs, and also a well-equipped bed of 800. The sampling is we use a consecutive sampling technique for all patients was CT confirmed diagnosis of intracranial extra-axial hematomas were being recruited in the 6-month period, and the eligibility to include these patients is all patients with CT proven intracranial hematomas who have been managed at our hospital, but patients who have been referred and who declined our management and went home were excluded from the study. The software we have used is Epidata version 3.1 for data encoding, and SPSS version 24 for data analysis. Now here we see two CT scan images which show lenticular shaped or biconvex shaped intracranial collection, which shows a typical collection of an epidural hematoma, and there is also a midline shift as it is seen on the left side of this patient, and there is also effacement of the ventricles, and by far the midlower side is a huge intracranial collection which entirely occupies the right side of the hemisphere with a significant midline shift, effacement of the ventricle, and also widening of the cell side. So the outcome measures we have used was the mortality or the hospital discharge outcome, as well as the Glasgow outcome scale. So the analysis was using both descriptive and inferential statistics of bivariate and multivariate logistic regression was run to differentiate the predictor variables. And a p-value of less than 0.05 was taken as statistically significant in the multivariable logistic regression. And coming back to one of the outcome measures is the Glasgow Outcome Scale. So it has the extended form, which has 8 classes, and the normal or the original form, which has 5 classes. So class of 1 in either classification is a dead patient, and class of 2 is a vegetative state. But on the class 3, severe disability is classified into low severe and upper severe in the case of Glasgow Outcome Scale of the extended type. So taking this all into consideration, at 30 days, all the patients accessed were classified according to this Glasgow Outcome Scale. And this is measured according to the patient's disability to perform daily activities, self-care, or the level of disability in which it pertains on the patients. So the surgical procedures and general management approach, which is the conventional type, was followed for the study period, and in all patients the usual management protocol was followed with respect to the types of intracranial hematoma. And in anesthesia, we've used general anesthesia for depending on the status of the patient, as well as the type of the hematoma, as well as we have used also local anesthesia based on the ability of the patient to cope with, specifically in the case of chronic subdural hematoma. Epidural hematoma, we use the standard craniotomy and evacuation, while in acute subdural hematomas we have used craniotomy with dural incision and evacuation, and in chronic subdural hematoma we usually use bar hole and drainage. Here, as you have seen, in the we are living in a very resource limited setup in which we don't have the plaster adhesive to put on the patient, so we usually we don't have the rainy clips to stop any bleeding. We don't have the saw to do craniotomy, but we usually do with bar hole, as you see on this image. With bar hole we drill some sites, then we use the jiggly saw, which is a wire which cuts the bone through, and then we do the craniotomy. And this is the brain with an intact dura and bleeding epidural arteries. Here we see a CT scan image of chronic subdural hematoma with septal formation. So in this particular type of patients, it might be important to breach the septum to drain all of the subdural collections. And here is the procedure we do to drain a chronic subdural hematoma. As you see, as that takes time in the epidural space, it turns into oily or darkish substance, and here we see the bluish tint of the dura. So coming to the results, the socio-demographic characteristics, so males dominate in this study. They account for 80% of the patients, and 91 patients, as I have said earlier, were recruited over a 6 months period, and the mean age was 34 years, ranging from 2 to 90 years, and 62% of these patients were in the reproductive age group, that is 15 to 49 years old. So mainly trauma is the cause in these patients, so only 6 patients have no recognizable cause, or they didn't elicit any history of trauma. Road traffic accidents and fightings account for 64% of all the cause, and the majority, more than half of the trauma, happen in the outdoor environment. Time of arrival to the hospital, we've seen that nearly half of all the patients arrived within 4 to 24 hour period. So this classification is very important, that if any operative procedure is done within 4 hours of the diagnosis of epidural conduction, so the Glasgow outcome scale as well as the overall outcome is said to be very good. So most of the patients arrived later than the golden period. And among the 91 study participants, 75% of the patients reported a history of loss of consciousness during the scene of the trauma time, while 16 patients didn't have any loss of consciousness. And nearly half of the patients had loss of consciousness at the presentation during our evaluation at the hospital, and body weakness have been in the 32 patients, from which hemiparesis in 27 and complete loss of power in 5 patients. Now, when you see the category of the TBI, nearly half of the patients sustained mild type of traumatic brain injury, followed by the moderate one, and only 14% of them suffered severe type of TBI. Extracranial injury accounts for 15.4%. This is accompanied by long bone fractures, abdominal trauma, chest trauma, and so on. So coming to the CT findings, 68% has acute epidural hematoma, followed by subacute subdural hematoma. And most commonly, half of the patients have hematoma volume of more than 60 ml, which is significant. So the in-hospital mortality was 11%, while at 1 month follow-up, more patients have died, which make the mortality rate at 1 month to be around 13%. So when you see the neurological outcome based on the Glasgow outcome scale, 61 has good, 4 has severe disability, and West has moderate disability. And when you see the cause of death, primary brain injury in 6 and respiratory failure in 4 were the cause of mortality. So the predictors of poor outcome when we run a multivariable logistic regression, a papillary abnormality of finding will have a mortality rate of by more than 9-fold, while an increased ICP has this much of mortality, and aspiration has by far the significant contributor of mortality, and it is well known these patients are at risk of respiratory failure and at significant risk for mortality. In low GCS, patients who have been in the CV range has also a significant rate of mortality. And in this study, although the proportion of patients is in line with increased risk of mortality, however, volume of hematoma, time of presentation, level of mid-diet shift were not significant predictors of outcome. So, acute subdural hematoma and epidural hematomas are the most frequent after effects of severe head injuries, and males are prone to these injuries due to their more outdoor activities and involvement in violence compared to the female counterparts. So the growing middle class, affordability of motorcycles, urbanization, and the lack of developed health system are all contributing factors to the rising prevalence of TBI, specifically in our country, and also this is true in the African setup too. And it is notified that if surgery is performed for subdural hematoma within 4 hours, mortality would decrease from 90% to 30%, which is a 1/3 decrement. A full decrement. But in most of our patients, even the arrival time is after 4 hours. Patients who have been managed in the earliest time possible has favorable Glasgow outcome score at 1 month period, and considering the setup, 15 patients were subjected to respiratory support, but only 5 of them got mechanical respiratory support due to the low source setting, limited number of mechanical ventilator machines. And the mortality rate for epidural hematoma was about 10.7%, while it is 43% for acute subdural hematomas, which is almost comparable to other studies and reports from other parts of the world. So coming to the conclusion, ICH is a major cause of morbidity and mortality worldwide, and its management is very challenging in low and middle income countries due to the lack of setups, and trauma is almost invariably the cause of intracranial hematoma, as depicted in the results of this study. Lower GCS, increased ICP aspiration, papillary rights were strong predictors of mortality, and mortalities are high, and many patients who survive experience significant disability in low countries. So as a recommendation, trauma is almost invariably the cause of intracranial hematoma. So policy formulations to enhance injury prevention and establish a better rehabilitation programs and facilities should be sought to, which is also a cost-effective investment. Thank you very much for the Jimma University Medical Center, for the TORG and study participants who makes this presentation possible.